Welcome back to another video, and this is part 2 of renal disorders, guys, and we're going to discuss 4 disorders in this video: that of polycystic kidney disease, pyelonephritis, acute glomerulonephritis, and renal cancer. So our first disorder is PKD, polycystic kidney disease, and this is a genetic disorder in which there are many cysts within the kidney. Now the cysts are manifested in the renal cortex and medulla of the kidneys. They develop due to the consecutive cell division that occurs in the renal tubules. In the image to the right, we see a normal kidney and a polycystic kidney, and it looks very scary, I know. Now the diagnostics looked at here, being that PKD is a genetic disorder, is going to start with the patient's family history to see if the disorder runs in the family, because remember, it is a genetic disorder. So also an abdominal ultrasound can be done, as well as an intravenous pyelogram, and this outlines structures within the kidneys using a dye. Lastly, a CAT scan can be done, and this is the most precise test done when identifying the kidney structures. Manifestations seen are things such as hypertension, which is that increased blood pressure, in this case due to the damaged kidney. Also hematuria, which is the blood in the urine, occurs due to the rupturing of the cysts, and lower back or flank pain. And this will all point to that renal discomfort. Headaches will be seen as well, and this disorder can eventually progress to end-stage renal disease, and that's going to be discussed in Renal Disorders Part 3 under the topic of CKD, chronic kidney disease. Now, the management for polycystic kidney disease are things such as hemodialysis or peritoneal dialysis. In hemodialysis, this is the more complex set of tubes where blood is filtered through and brought back into circulation. Also, hemodialysis takes place in the hospital or dialysis center, and this should be performed about 3 times per week for 4 hours each time. Another thing that we can make note about hemodialysis, it is in this form of blood filtration where the creation of vascular access is done by means of an AV fistula or graft. Pretty much the AV fistula creation is created through an artery and a vein, so hemodialysis is the more complex form of treatment. Now, as for peritoneal dialysis, it provides more freedom and simplicity. A tube is placed in the abdominal cavity, and exchange of fluids occurs there. So this is the chosen modality for the busier individual because it is a 15 to 30 minute process. Analgesics will be given for the pain present. Non-opioids such as Tylenol and opioids such as morphine are examples. Next is the implementation of antihypertensive medications, and these are going to reduce our blood pressure. ACE inhibitors are examples, and our ACE inhibitors ends in pril. Think april. Examples include captopril, lisinopril, ramipril. And lastly, the only cure for PKD is a full renal transplant. And if that's the case, we're going to want to implement those immunosuppressive medications to prevent an immune response, okay? Nursing management begins with dietary modifications, and we are going to want to reduce electrolytes such as potassium and sodium, because being that the kidneys have cysts, these electrolytes as well as other substances aren't fully being excreted out of the body. And if that's the case, there can possibly be electrolyte imbalances and buildup of various substances. That's also why we're going to put these patients on fluid restrictions, because proper filtration has been compromised and there may be possible fluid overload. And lastly, administering medications as needed is going to be important. Now guys, we get to pyelonephritis. This is the opposite of urinary tract infections, and urinary tract infections can lead to this disorder, pyelonephritis, okay? And UTIs was discussed in Renal Disorders Part 1. Now the risk factors for pyelonephritis are things such as UTIs and pregnancy. Pyelonephritis is the inflammation of the renal parenchyma and urinary collecting system, and it is a bacterial infection, guys. And when there is infection, we're going to see manifestations that are signs of infection. So we're going to see a fever. Remember, a spiked temperature in response to infection, which is an increased temperature to help, kill or get rid of any bacteria within the body. Also, we might see chills and nausea and vomiting. And remember, that fever is what distinguishes pyelonephritis from a UTI. If there is a fever, we are in a state of pyelonephritis, not a UTI. Also, there will be back and flank pain. There will be costovertebral tenderness. And lastly, there will be signs of a UTI present, such as burning upon urination. We'll also see hematuria, frequency to urinate. Also, the urge to urinate may be present, and dysuria, the pain upon urination, will be present. Diagnosing disorder can be done by lab tests and CAT scans as well as an ultrasound, guys. So treatment for pyelonephritis is going to be hydration after diagnostics to hydrate cells or rehydrate the cells. Also providing an antibiotic to get rid of the bacterial infection present is important. And something named trimethoprim sulfamethoxazole, which is also named Bactrim, is going to be used, or ciprofloxacin fluoroquinolones, which are a group of antibiotics. Now, asking if the patient is allergic to sulfa is going to be important because Bactrim, that trimethoprim sulfamethoxazole, which is so annoying to say, this has sulfa in it, as it is in the name. So we're going to want to make sure that they are not allergic to sulfa when giving this antibiotic. Also, guys, analgesics are going to be used, such as NSAIDs, which are going to reduce pain and fever. Also, narcotics are used to reduce the pain, and pyridium, which is that urinary analgesic, that's going to reduce dysuria, and it's going to cause orange colored urine. So again, we're going to want to educate the patient on the urine change in color so that the patient doesn't go crazy. So nursing interventions for pyelonephritis is going to start with education, guys, teaching about the avoidance of contracting any UTIs. So we're going to want to tell them to clean front to back when providing self-care or when toileting. Also to tell the patient to monitor for early signs of infection and relating that information, such as an increased temperature, which may be signs of a fever, or pain when urinating, dysuria, to someone or to a health specialist. Also reminding them to complete their antibiotic therapy so there will be no antibiotic resistance is going to be very, very important. Reminding them to increase their fluid intake and try to void frequently is going to be important to prevent any urinary stasis. We're going to want to get the fluid out of the body. Remember, we don't want urine sitting there because that can cause a UTI, furthermore causing pyelonephritis, which is the complication of a UTI. And we get to our second to last disorder, which is acute glomerular nephritis. This can either be an acute or chronic disorder, and factors that contribute to it are things such as infections, immune diseases, a high blood pressure, and diabetes mellitus. Now, this disorder develops very rapidly, insidious onset. Now, of all of the risk factors listed, infections are the main trigger of the acute glomerular nephritis, guys. So infections are the main trigger. So clinical manifestations seen are things such as hematuria, along with edema leading to that ascites. Remember, ascites is the buildup of fluid in the abdominal cavity. There'll be edema because of renal compromise. Nothing is properly being excreted from the body, and due to that, oliguria will be seen as well, which is a decreased urine output. And due to the fact that fluid is within the body, hypertension will be seen as well, okay? Fluid is in the vascular system. Also, guys, there will be elevated lab values due to the lack of excretion of them, such as BUN and creatinine. Now, management for acute glomerular nephritis is going to begin with antibiotics. Penicillin is the antibiotic of choice for acute glomerular nephritis, and diuretics are also going to be implemented to get fluids out of the body. Diuretics such as Lasix and Bumex are examples. Antihypertensives are also going to be implemented, and these are going to decrease our blood pressure. Remember, ACE inhibitors such as lisinopril are examples, and are ACE inhibitors and in pril. Another treatment for the disorder is a plasmapheresis, and in this procedure, blood plasma is removed as well as immunoglobulins that are involved causing any complications. And lastly, guys, rest is also going to be important to assure proper healing, and it's rest. I mean, who doesn't want to get some rest, you know? Now, guys, we're going to want to monitor vital signs and do daily weights, monitoring for that fluid loss, okay? So looking at intake and output is going to assure proper ingestion and elimination is occurring. And measuring the abdominal girth of the patient is useful to make sure fluid within the abdominal cavity, termed ascites, is reducing. We want a flat tummy or a returning to normal tummy. Okay, monitoring dietary intake is going to be important, and that is also going to tie in with patient education, such as telling the client to reduce their protein intake because the kidneys are not functioning. And when the kidneys are not functioning, guys, various substances such as protein, which correlates with amino acids, are not going to be excreted, okay? And our last disorder in this topic is renal cancer, and this is tumors within the kidneys that compress underlying tissues. And when underlying tissues are suppressed, circulation is as well. Therefore, there will be decreased circulation within the renal structure. Now, renal cancer occurs more often in males than in females, usually around the age of 50 to 70, and it has a genetic epidemiology. Now, the risk factors are things such as tobacco use, genetics, obesity, and hypertension. And as always for cancers, carcinogen exposure will trigger carcinogenesis, the creation of cancer cells. Now, here's the stages of renal cancer, and cancer has 4 stages, guys. 1 being the least complicated, and 4 being the most complicated. This is the Robson system of staging renal carcinomas. And in stage 1, the cancer is limited to the renal capsule. In stage 2, it progresses to that of the adrenal glands. And in stage 3, the cancer then spreads nearer to lymph nodes as well as the renal vein. Lastly, stage 4 is where metastasis, which is the full spreading of the cancer, begins. And stage 4, the cancer is metastasizing to other body regions. Now, it is here in stage 4 that chemotherapy is going to be implemented in the plan of care, guys. Now, immunotherapy is a treatment for this type of cancer, and it pretty much boosts the immune system to fight cancer. Surgery is also a route that can be taken, and depending on the severity of the cancer, such as stage 2 and 3, something called a radical nephrectomy can be done, and this is the removal of not just a kidney, but also the surrounding tissues that may be affected. The removal of the kidney before stage 4 prevents further metastasis from occurring, and in stage 4, a nephrectomy is contraindicated or should not be done because the cancer has already spread to other body parts. Therefore, it would be too late to remove the kidney because the cancer is already out and about. Now, if both kidneys are removed, the doctor will create a iliac conduit or a urinary conduit. And this is a drainage system the doctor will create to get urine out of the body. And this drainage system is made by using the small intestine or a piece of the small intestine, furthermore creating a stoma. That red outpouching you see on the image to the bottom right, okay? And the stoma should always be bright pink or have this reddish appearance, okay? So we're gonna have to check that stoma throughout the plan of care if one is present, okay, guys? And that is the end of this presentation. You can follow this video up with Renal Disorders Part 3, in which we will discuss acute kidney injury and chronic kidney disease. So I'll see you guys then.